Arun, Dr. Arun, where are you? I would like to invite Dr. Arun, gastroenterologist, NMC specialist, Specialty Hospital, Abu Dhabi. Dr. Arun completed his education in Kerala. 2007, he started practicing in Kollam, India, gastroenterology for 3 years. Prior to joining NMC, he was the head of gastroenterology department at Ahliya Hospital, Abu Dhabi, for 4 years. Dr. Korah completed a fellowship program in functional bowel disease from Sanjay Gandhi Postgraduate Medical School in Lucknow. When he came to Abu Dhabi, I was examining gastroenterologists who are supposed to have a license. And whenever I asked him questions, he was perfect. So I said, let me show him that one question was about the worms, is it?
Yeah. You asked about Colonoscopy silences.
So we will hear what you say about how to achieve, about clonosis, I think, yes?
I was also surprised that I knew about Colonoscopy silences, and you were surprised that I answered it.
Thank you.
Now you know how old is he now. Okay.
How to achieve optimal colonoscopy preparation.
Thank you, Dr. Salim, for this wonderful introduction. Thank you, Yogesh, for giving me this opportunity. And also thank you for giving me a very shitty topic. So, too much stool and a good colonoscopy don't go together. So you don't want to be in this situation when you're inside somebody's colon. So, basically, if preparation is poor, how common is poor preparation? Almost 25% of all colonoscopies generally have an inadequate preparation. It could be because of patient-related variables like patient doesn't properly comply with the instructions, medical conditions like constipation, opioid use, etc. And even sometimes we are at fault. We post a patient at 11 a.m. and we do at 4 p.m. and it can be poor. So what is the issue when the preparation is poor? One, you are likely to detect adenomas, longer procedural time, lower rates of cecal intubation, increased risk with use of electrocautery, and you are forced to repeat a colonoscopy which should be repeated ideally after 10 years. Within 1 year you might have to repeat it because the preparation was poor. So any colonoscopy, it is a must that we must grade the preparation. The most popular grading is the Boston preparation scale, or the BPPS. So it was initially published in the year 2009. Basically, you divide the colon into two sides, three segments: the right, transverse, and the left. And let's suppose it was all the sides were very clean. Then it is 3 plus 3 plus 3, 9. Of 0 score if all the 3 segments had a lot of stool. So you should use a chart like this to grade the quality of the preparation. And generally speaking, preparation the score more than 6 would be considered as adequate, though not perfect. You should always try to achieve a score of 9. And if suppose any center has a more than 20% poor preparation rates, you should actually really assess what is the issue in your center in terms of communicating with the patient and in terms of which prep you use. You should really look back and see what is happening. There are many other grading criteria, the Ottawa, Aronchik, the Harfield cleansing scale, and the Chicago bowel preparation. But overall, the most popular one is the Boston scoring system. So, how to better prepare your patients? You should start much before the actual date of colonoscopy to achieve a good preparation. So, first thing is the pre-procedure diet. So, traditionally a clear liquid diet used to be advised, but the problem with the clear liquid diet is adherence is likely to be very low. And studies have proven that a low residue diet may be acceptable. And how many days should the patient adhere to this sort of diet? The longer the change in diet is needed, less compliance is going to be. So, suppose you are going for a split dose preparation, a single day of low residue diet is enough. There is no advantage of going for a multi-day low residue diet. So, this is a very important slide, especially important. I think this is one list we need to give to the staff also who is advising on what to eat, what not to eat. So, if you look at the big slide, I think we should get a copy of this and give it to our staff who post patients and advises patients. If you look at some key points I'll mention, most milk products are good, they can be allowed, but nowadays a lot of these yogurts contain seeds and pieces of vegetables and fruits. So plain yogurt or milk products of any type is okay. Then among vegetables, potato without skin is acceptable. Most other vegetables are not acceptable. And among meats, most meats are acceptable, provided you don't put a lot of nuts and seeds when you're making that meat curry and most grain, coming to the grain products, bread, pasta, cereals are okay, but avoid whole grain bread, brown rice, which contains a lot of residue. Among the fruits, all raw fruits except apple and ripe banana should be avoided. Beverages, any clear beverage, but try to avoid things which are red in color or black in color. And condiments, butters, oils, mayonnaise can be allowed. So, next thing would be about the preparation. Drinking a clean prep is like drinking soap water. I've experienced it myself. I tried it. It tastes like soap water. So, how do you make it more palatable? So people have conducted not very large trials, but small trials where they have tried Coca-Cola instead of water, orange juice kept in the mouth for a few seconds. Along with that, you drink the prep. And basically, better speed and better bowel cleanliness has been found when these techniques have been tried. And generally, patients tend to be willing to go for a second procedure later in case you need it. If you are you are doing some sort of techniques which make the drink more palatable. And some interesting techniques which have been tried is chewing gum in between while preparing. Then candies, lozenges, lollipops are all techniques which can be used to make the prep more palatable. Then green tea along with 2-liter pegs have been tried. So this is a very key topic. How to give instructions. It has been consistently proven that enhanced instruction techniques will help with preparation. There are a lot of trials and data from various centers across the world where people have used visual aids, social media applications, mobile applications on Android and Apple. And a simple technique would be sending a video. If you can't develop an application or a SMS system, sending a video in the patient's language to their mobile phone would be a fantastic low-cost technique to actually improve preparation. Patients are not going to remember all the instructions. So sending a YouTube link on their WhatsApp might be a good solution. And along with the prep, some people suggest the use of oral simethicone along with the bowel preparation. The European Society Act of GI Endoscopy suggests this, adding oral simethicone to bowel preparation, even though the recommendation is weak. At this point, I just want to mention one more thing. Many of us use simethicone in the lavage fluid during our procedure. Is it safe? It is safe, and it does help us a lot when there is a lot of bubbles and all that. But make sure you don't use it through the auxiliary water channel, because simethicone residues form biofilms where bacteria can grow. And always inject that through the biopsy channel. Does prokinetics or enema helps? The recommendation is against the routine use of prokinetic and enema. And when, next is when to prepare. This is a very key point. Right now, what is strongly recommended by all the societies is split dose preparation for elective colonoscopy. It is better cleansing, better tolerability, and actually the data suggests a better polyp detection rate, especially when it comes to right colonic polyps. But suppose you are planning an afternoon colonoscopy, then a single day bowel preparation is an acceptable alternative. The one advantage of this is better quality of sleep for the patient and better tolerance. And one more issue is that when you go for a split and post the patient for 4 p.m., there is a high chance of a bigger gap between the second prep, the last dose of the second sitting of prep, and your timing, which will also lead to a poorer cleansing. If you go for an afternoon case, 4 p.m. case, and you advise a split dose preparation, the issue is that first, the last prep drink might be taken at 9 a.m. So that will actually lead to a bigger gap between the last dose of prep and the colonoscopy will actually lead to a poorer cleansing. So this is about what I was talking. Once, make sure the last dose of bowel preparation is within 5 hours of colonoscopy. So the ideal time would be between 2 to 4 hours. And to make your anesthesia guys happy, the last intake of the last dose of preparation, the interval should be more than 2 hours. So the best option is between 2 to 5 hours. Now, the question of how much volume to give. You can go for a high volume prep, which is more than 3 liters. And that appears to be superior when you use PEG alone. However, there are a lot of options. Drinking 4 liters is not easy. So newer preparations are available where 2 liter PEG with ascorbate, 2 liter PEG with citrate, 1 liter with higher dose of ascorbate, and 2 liter PEG with bisacodyl. This is commercially available. Most of this we can manage by prescribing the bisacodyl as a separate dose. This combination is commercially available. So then you have the non-PEG options where magnesium citrate with picosulfate. But the issue with these agents are there is a slightly higher risk of complications, especially in older patients, especially patients with cardiac issues, hypermagnesemia, renal dysfunction, etc. This magnesium with picosulfate can cause problems. Then A newer agent which is getting more popular is trisulfate, where it's a combination of magnesium sulfate, sodium sulfate, and potassium sulfate. Again, it does have an issue of it is contraindicated when there is cardiac, congestive heart failure or renal insufficiency. If you look at the risk, PEG is the safest option in any setting. And there are some older agents which are still popular, like high-dose Senna. But the problem with Senna being a stimulant laxative, more cramps and abdominal pain is common. You can actually try low-dose Senna with, that is another combination, with 2-liter PEG. So these are different brands available, easily available in Abu Dhabi. This is, I think, the most popular agent. And this is also widely available now. Only thing is, since it contains only macro gold, one good option would be supplement bisacodyl with this. And you have the agent called picoprep. So, how to deal with special populations like elderly? In elderly, there is insufficient evidence to recommend a specific product, but overall, PEG is safer and avoid anything with sodium picosulfate. Then, when it comes to how do you prepare your IBD or an ulcerative colitis patient, always avoid sodium picosulfate because that itself causes inflammation of the bowel, which will mimic colitis in up to 3 to 5% of patients. So again, IBD, PEG is the best option. In pregnancy, there is no data, but PEG is safe in pregnancy and that might be the best option. And in bariatric surgery, because of the accelerated gastric emptying, you should try to, even though there is no data or recommendation, but extended time or a low volume prep should be advised. And when it comes, another suggestion is, this is very important just in case you are stuck with a patient with rectal bleeding in a pregnant female, avoid fleet enemas and tap water enema should be used in sigmoidoscopy for pregnant females. Similarly, avoid non-PEG preparations in renal disease because of magnesium toxicity and potential acute phosphate nephropathy. So you are in a situation where a lower GI, massive lower GI bleed comes to you. You feel like putting in your scope right now. Actually, it is always better to avoid that, stabilize the patient, and go for a proper PEG with a 4-liter PEG solution or an equivalent and administer it over 3 to 4 hours. And at this point, one thing I would like to mention is we also have this issue of our staff knows how to tell the patient and make the patient ready for a colonoscopy. But don't assume that your inpatient ward staff knows everything about a colonoscopy. They might not be familiar, they might be new, they might have a lot of misconceptions of how to prepare. So always give specific instructions, preferably written instructions to in case of to the patient and to the staff when you're dealing with a hospitalized patient. And this is a recent study from Turkey where actually immediate unprepared polyethylene glycol was used. But this they used a special jet device. So when the patient comes to the ER with a lower GI bleed, you would get into the colon and use a special jet prep machine to push in polyethylene glycol and flush the colon. It's a very small trial, but I found it interesting. I just mentioned, I don't think we can do this. We will have to stick with this 4-liter PEG over 3 hours in any massive, insignificant lower GI bleeds.
Immediate.
So, what are the predictors of colonoscopy? Bad colonoscopy preparation. One is older age, male patient, long-standing diabetes, patient with stroke, dementia, patients on opioids and tricyclic antidepressants, previous surgeries. If your patient had a very bad preparation a couple of years back, it's the same patient, the same colon, be careful. And generally, hospitalization because of patient's activity, poor instructions, etc. Generally, inpatient colonoscopies tend to be poorer prepared.
2 minutes.
And do you have any techniques for patients with severe constipations? There is no evidence supporting a special regime. However, in case of difficulty, one option is to start daily PEG 1 week before the colonoscopy. Enema given on the day of the colonoscopy or increasing the volume of the cleansing solution have been suggested. So if suppose there is a preparation is inadequate, what is the recommendation? Repeat colonoscopy within 1 year is the standard recommendation. But other options are repeat a colonoscopy. Suppose you have given a 4-liter PEG, then once the patient wakes up, start a 2-liter PEG and try to do it on the same day. Or people have tried like patient is asked to go for a 3-day low residue diet and then a 4-liter PEG with bisacodyl. Or another techniques people have used is additional Senna with 1.5 liters of water and repeat the colonoscopy on the same day. These are all techniques which we can use to speed up rather than post a patient later. So there is another technique which has been used is, you find it is a bad prep. Once you get into the right colon, you can push in 500 ml of PEG. And you come out, patient wakes up, walks around, and do it as the last case in the evening. And people have gone to the extent that you push in PEG, then make them later 2 liters of PEG, push in PEG into the right colon, and along with that make them drink 2 liters of PEG and post the patient on the same day later. And this is a jet prep cleansing device. This is a disposable device where you can actually push in water and suck at the same time. It's a disposable single-use device. I think Medivators is marketing this. So if you're convinced, this is something I use, if you're confused, is the guy prepared? Before putting your scope, if you're not clear, show them this photo on the mobile. How does your stool look before flushing? This can also be very helpful. So let's hope our patients will be like Frank out here. How was your colonoscopy? In, out, very fast and clean. Thank you.